Hi, everyone. So we're going to talk about low back pain and a review of the evidence today. So I'm Dr. Cody Rondeau. I did my Bachelor of Kinesiology at the University of Alberta, and then after that went to the University of Western States, where I did my Doctor of Chiropractic. Um, and then currently I am a clinical instructor at UBC's Northern Medical Program, where I teach first year medical students clinical skills such as neurological exams, file exams. And then I work full time at Crowell Wellness. And then I also do some work with the Prince George Spruce Kings BCHL team, where I do concussion management and some sport performance. And then this is a picture of me running very, very slow at the Gorge Waterfall 100-kilometer race in Portland, Oregon. So, objectives of this presentation: what is back pain, how we diagnose it, how we treat it, and then when we refer for it. So, why it matters? Because people have it. It's really common. Most people are going to get it some point in their lives, and it's a common cause of work loss, disability, and then it's a lot of resources for the healthcare system. A lot of these are managed by their um, general practitioners or going to take up time in the ER, urgent care, things like that. Things that could probably be managed better with conservative care elsewhere. Is it serious? Most of the time, these things are generally non-serious. Roughly only 2% are going to have actual pathology where it's cancers, fractures, cauda equina infection, things like that. The rest we can group into non-specific low back pain. We used to, or there's still some people who diagnose into categories and things like that. And I think there's some utility in some diagnosis. Things like your disc herniations with radiculopathy. That's obviously going to have a very obvious cause. Uh, but for a lot of people, it's just I have low back pain, um, and it's difficult to put a specific structure. And as we're going to talk about pain in a second here, a specific cause. So in acute episodes, these are generally going to improve on their own within 2 weeks, but we can have some lingering symptoms for 2 months before things are getting like fully better and people are getting back to normal. So this was data that the Canadian Chiropractic Association hired a team to survey data on, and the BCCA uh, help fund it to get more emphasis on BC statistics. So we can see lifetime prevalence in BC about 80%, 40% of people seeking care, quarter of people are missing work, and the 10% going to the ER for their back pain. So if it happens once, it's likely going to happen again. We have a pretty large confidence interval, but up to 8% are going to have another reoccurrence within a year. And that's normal. And I think that's an important message for patients that, hey, this is, just because you have gotten rid of back pain doesn't mean it's not going to come back, but also doesn't mean that like something else has gone on or your back is getting worse or things are uh, continuing to evolve, trying to prevent that catastrophizing. Um, and then your 2 to 7% are going to go into your chronic back pain, and this can be influenced by a lot of other things, psychosocial factors, work demands, prior episodes, things like that. And we're once again going into more pain science stuff. We'll get into that. So key messaging for patients. Uh, Low back pain, extremely common, often recurring. Most cases are non-specific, self-limiting. Only a small minority involve serious pathology, and that's kind of why they're seeking your care to make sure that things aren't serious, that they don't need to be referred out. Primary care decisions are going to drive your outcomes, especially that messaging and education piece. And then your evidence-based conservative care is an important part of their recovery. So explaining pain. Pain's complex. We used to think there was like tissue damage equals pain. That's why people are in pain. There's, just a purely structural component. But we know oftentimes there's psychological and social factors that influence pain. Um, so on the one side here, we can see, all the things that kind of affect pain. So your tissue damages, but also, um, you know, how your work environment is, stress, mental health, a lot of those other things. And I don't always go into really in-depth like pain education with every patient, but pretty much with every patient, I'm going to give them, our two goals are to calm things down and to build things up. Decrease what's causing you pain, increase the factors that are uh, getting rid of that pain. So my favorite way to explain pain is an analogy by Greg Lehman. He's a really good pain and science educator. So imagine your cup, and then everything that affects your life goes into your cup. So these are like physical stress, fear of movement, your mental health, um, frustration, lack of support is a big one. False beliefs is another really big one. So when your cup overfills, that's when you're going to start experiencing pain. So then there are two things that we can do to get you out of pain. We can either reduce things in your cup, or we can build you a bigger cup, right? Calming things down, building things up. And I think for patients, another key message of this is your cup doesn't have to be empty. Like we know people have a higher rate of pain when they have arthritis, but at a certain age, everyone's going to have arthritis. So it's more to say that you can still have arthritis. That can still be part of what's in your cup. But if we can reduce all these other factors and build the capacity of your cup, then we can get you out of pain and live a as normal life as one could hope for. Um, and how big your cup I is isn't just your physical resiliency and your physical capacity, but also your mental capacity. And we're gonna incorporate that into some of our treatment guidelines and how that fits together as well here. So managing patients with pain primary care. Um, First one, like be a good doctor. Use your clinical judgment, document it, reassess, make sure you're not missing anything. You use a multimodal biopsychosocial approach. Um, a lot of things influence pain. There's a lot of things we can do to help people with pain. Prioritizing function over pain elimination. I think that's a really important one, especially these like really tough chronic pain patients, um, is to, you know, have them continue living their lives and focus on like, hey, I know you're in a lot of pain right now and that's your kind of focus, but if we can get you doing those things you're avoiding because of the pain, one, your life is going to be better, and two, it's probably going to help the pain. And realize that, hey, I can do this, and my back isn't as fragile as I thought it was. And then with that, you're building that, supportive therapeutic relationship. Um, so yeah, like when kids uh are playing, if their parents nearby, they're gonna engage in like more risky behaviors, and they're gonna be willing to take more risks and really push themselves because they have that support. because there's that physical and emotional support with their parent there. I think the same thing is really true with our patients. Um, when you have a good relationship with your patient and they trust you and they can say, hey, if I'm in a little pain, if I flare things up, I know I can see them and they can help me out with this. They're more likely to go out and do those things that are fulfilling in their lives. And you're going to see that, they get better when they do that. And you're going to see them less, and you're going to have a more satisfying outcome for everyone. So red flags, things you don't want to miss, right? Your cauda equina, infection, fracture, your malignancy, just things that everyone should be aware of. And then the yellow flags, the things that I think are important for, so the red flags are for serious pathology, yellow flags are for now it's non-specific. How much is this a tissue thing? How much is what else is in their cup? So that lack of physical activity, poor deconditioning. Um, so how big their cup is, right? And then how bad is their disability? Your mechanism of injury, um, poor sleep, things like that. And then psychological factors, mental health, stress, depression, um, other things like that. And then social context. Um, how many people do we have that are in car accidents and they're really scared to drive, and they have a lot of fear and anxiety around that. People who were assaulted and they're just scared of going outside and being in the world. Injured at work, and they're stressing about their boss, and um, going back to work and being in a non-support environment. So then we have our diagnosis. So imaging, acute low back pain, basically just imaging if we see those red flags. Um, and we're going to go into like why we don't take routine images on everyone in a second here, but um, you know, cancer history, unexplained weight loss, all the things that are popping on the radar. Yeah, you want imaging. Otherwise, conservative care. And then your things where you want to take, or sorry, radicular symptoms. So if these are happening, um, if they're going on for greater than 6 weeks, then it's okay. We need some imaging to see what's going on, why this isn't progressing the way we want it to. Um, and but if not, we're good to manage conservatively. Uh, 3 out of 5 motor weakness is the one that I start to send people out for imaging, because that's when you can have that long-term motor loss. Sensory reflex deficits, not too worried about. 4 out of 5 muscle strength. That's another thing where the muscles are still firing enough. That's something that we can build on and get better conservatively. And then lab testing, once your cancer, fever, unexplained weight loss, this is when we need to refer for the blood tests to see what there's something systemic going on here. And then why imaging isn't always helpful. So most acute low back pain improves within 4 weeks of imaging, without imaging, sorry. And it doesn't speed up recovery. Um, and you can only see so much in image, and it's only so much of that cup, right? And so if we image a patient and we say, hey, look at this, look how degenerated your spine is. Your degenerative disc disease, you have all this arthritis. Um, Odds are, like, especially when it's acute, they already had that before. and now you're playing into, you're creating that nociceptive language with patients, and they're saying, okay, now I have that, I'm gonna have pain forever, when you know you can have that without pain. It's part of your cup, but not all of your cup. And then here we can see um, your, so this is a meta-analysis of degeneration off of asymptomatic patients. So we can see things, your disc generation, disc signal loss, disc height, based on your age. And we can see that, once you hit, even before in your 20s, a really high percent of people are going to have some kind of disc degeneration. And the older you get, the more common that's going to be. So a lot of these things aren't things causing pain, they're just part of natural aging. So then going into guidelines for low back pain, for managing, we're using the Pearson Flag Chronic Pain Guidelines. It's developed in 2022 by a multidisciplinary committee, family physicians, pain specialists, pharmacists, PT, NP, psychologists, and they had a patient representative for it. And it just goes on for a review of evidence and what is actually making people better. So general principles of it, and we'll hit each point more specifically, is physical activity, exercise is going to be your foundation. Patient-centered, shared decision making. Uh, we have the different ideas of how involved patients should be in based on the diagnosis. Like when patients have heart attacks, they don't get a lot of say of what's happening with them. It's like, we're going to do this to save their life. When, you have non-specific low back pain, it's more of a collaborative effort of what is the patient's values, what do they want to do, and how can you manage it together? And then that functional goals over pain elimination, and then your cautious use of medications and interventions. So first line, physical activity. So that's going to be the biggest bang for your buck. And going back to our cup, this makes sense because increasing physical activity is going to increase the size of your cup. So the larger your cup is, doesn't matter what's inside, the more you're going to be able to handle that thing. So 2/3 of people who increase their physical activity notice an improvement in their pain. What they do for physical activity doesn't seem to be um, make a huge significant difference. And especially, people always complain about, oh, my patients don't do their exercises. And I think some of that has to be on us of giving the wrong exercises or giving exercises that don't match the patient's goals or the patient's not motivated to do. So having goal-oriented ones where you haven't been golfing because of your pain. So let's get you golfing at a level that's scalable, that isn't irritating things, and building you up and periodizing your plan based on that. And then wearable activity trackers. So I'm training for a half marathon right now, and I want to get a little bit leaner, lose a little bit of weight for the race. So I recently started tracking calories for the first time in my life, and it was a really big shock for some things, like coconut milk. Like a can of coconut milk was 700 calories, um, and so I think for me, um, I'm not the kind of person that's going to rigorously track every single calorie, but it was a good idea to see kind of where my baseline was, how many calories I was actually consuming. Um, and so the same thing can happen with wearable activity trackers. People can use it as a goal of, I want to get this many minutes of physical activity, or I want to take this many steps, and I want to set that as my primary goal. to hit every day, every week. Or it can be a good idea to just show patients how much they're actually moving, because a lot of people are overestimating of, you think you're taking 7,000 steps a day and really you're taking 3,000. And they can say, oh, I'm actually doing less than I thought I was. I need to start working on it more. And then psychological and mind-body interventions. So things like cognitive behavioral therapy have been shown to help people with chronic pain. And this is the same thing. These are a lot of strategies that increase your mental resilience. And so they're going to build your cup in that capacity. But also working on fears, stress, things to manage and take those psychosocial factors out of your cup. Treatment options. So for a chronic low back pain, things with clear evidence of benefit. So your NSAIDs, TCAs, SNRIs, but then spinal manipulation is also on there. And so these things are all going to provide temporary relief. And I think there's some people who will say that as a negative thing of like, oh, you're only doing the effects are temporary, so why would you do it? And I don't think that's true. I think it's really important to take away some of that discomfort for patients, and then also letting them see that, hey, um, I can get better, and this can improve, and creating that positive momentum, and especially using them to help with your physical activity. So if they're having trouble walking, 2,000 steps a day, they're having a lot of pain, and you can take some, and you can do some adjustments or give them medication that allows them to do 5,000 steps. That's a huge difference. And that can create a huge impact in patients. And then unclear benefits, your acupuncture, uh, your uh, your lotions and things like that. Um, and then corticosteroids, uh, evidence of no benefit, and then your opioids, your cannabinoids, showing that those are probably not an appropriate option for the patient, as they have more harms than potential benefits. So spinal manipulation therapy, what is it? So hands-on, quick stretch of the joint using high velocity, low amplitude thrust. So we're stretching the joint. As it stretches, it decreases the pressure inside the joint capsule where there's fluid, and inside that fluid creates some air bubbles, and that's the pop you hear is those air bubbles forming. Um, Generally really safe, pretty rare for those like strain sprains, rib fractures, injury aggravation to discs. But the most common ones we're going to see patients going to be a little bit sore for a few hours, occasionally a day or two, but we're getting better after that. Things to avoid: long-term use of opioids, especially for the chronic pain. Um, Use of cannabinoids, uh, polypharmacy, relying on multiple different medications, and then your reliance on passive therapies only. Um, Making sure that you're not just doing your adjustments, you're not just doing your massage, that you have other things incorporated into your treatment plan. So practice principles: shared decision making essential, set realistic functional goals, um, one intervention at a time, or as few as we can see benefit from at a time. Stopping our ineffective medications or interventions. If something's not working, just not like, oh, hopefully it works today this week. And then using our lowest effective doses, and then prioritizing our conservative care options. So key points: pain's complex. We should be using exercise as our first line of defense against it, and encouraging that for patients. where appropriate, having cognitive behavioral therapy and mindfulness approaches to help patients. Um, Medications and like temporary relief can be positive, whether that's your medications or your adjustments, your massage, things of that nature. Um, and then setting, realistic goals, sharing in that decision making, and then making sure that you're monitoring that patient and you know how things are going, reassessing. So this is the Center for Effective Practices and their recommendation. Um, and so they do have a recommendation for manual therapy and referring for that for MSK pain. Um, and you see in there is that patient education comes up, exercise comes up, also your manual therapy. Once again, calming things down, building things up. When to consider manual therapy referral. Um, so persistent recurrent MSK pain, if they're not getting better with what they're doing, once again, change it up. And this goes both ways, where your manual therapy isn't working, let's explore other options. Patients prefer it. They want to have that, non-pharmacological therapy. They want hands-on. They've had success in the past with chiropractic, or they want a more multimodal plan. They want to try a few different things and kind of seeing what works. Um, and then the Serial Low Back Pain Initiative. So this was a program that gave patients access or better access to a chiropractor early on and looked at how that affected patients that were going into a healthcare team. And it had, really good results. We saw people increasing their daily activities, functional capacity, lower pain levels, and in general, people were really happy seeing the chiropractor and having that conservative care option. So, best clinical practice principles. Um, so we want to individualize patient education. We want to engage patients in shared decision making, exercise as a foundation, and then refer to appropriately trained practitioners. Uh, and I have a slight modification of this kind of thing is, what we can do for our patients. Um, I think a lot of us get caught up in the identity of, oh, I'm a medical doctor. I give out medication. I'm a chiropractor. I do adjustments. Um, and that's only one piece of what we can give to patients. And I think it is probably the lowest on the tier. If you're to tier these, the lowest on the list. Um, Individualized patient education, teaching patients that, your spine is stable. It's not out of place. It's not something that's damaged. It can get better, and teaching them about pain and um, creating, realistic ideas of what's happening and developing your therapeutic alliance with them. Having them trust you and feel supported and listened to, because that's a lot of times what happens is people don't feel listened to when they have pain. They kind of brushed off, or they don't get enough time with their practitioner, where they're just like, you know, getting lip service essentially. And then the big one is, once again, including exercise as your foundation, getting them moving, getting them active. And that's not just about, getting out of pain, because we know pretty much the healthiest thing you can do is engage in physical activities, building up your, cardiovascular system, building up your strength. Um, and summarizing, I mean, we've hit all of these, multiple times, and we hit in the last slide. Um, So, thank you for letting me present this, and big thank you to the BCCA for helping putting this on. Thank you.